Hello friends, greetings of the day. Here I am again to share some interpretation of abnormal ECG as part 2 of my talk. Earlier we had discussed interpretation of the normal ECG, and today let us learn something about the abnormal ECG and disease specific ECGs. Here we go. So let me come on to the slideshow, please. All of us know that as many ECGs as we see, more and more experience we have in interpreting abnormal ECGs at a go. So what I'm going to do is tell you something about chamber enlargement and hypertrophy, various bundle branch blocks, and specific disease patterns pertaining to various elements of common interest to all of us. Let's go to chamber enlargement or hypertrophy. So we know that right atrial hypertrophy, left atrial hypertrophy, and biatrial hypertrophy can cause certain specific changes in the ECG. And we see mainly two leads here, that is lead 2 and lead V1. As in the normal ECG, we know that lead 2 P wave is absolutely 2.5 millimeter in size, less than that obviously, and not very peaked. Here what will happen is that if you see, you will have a tall and peaked P wave and maybe slight slur on the downstroke. In lead V1, what you will note is that the positive deflection generally is not very large. Here the positive deflection will be quite large, followed by the left atrial deflection. In left atrial hypertrophy, what will happen is it will become a bifid kind of P wave in the lead 2, and it will be depicted as initial deflection of the right atrium followed by a large deflection of the left atrium as well. And in the V1, what you will have is bifid or negative terminal deflection of the P wave will be more than 1 millimeter. In the right atrial enlargement, there are tall and peaked P wave. This is one of the ECG. If you see lead 2 showing a tall P wave, also known as a P pulmonale, and it is often associated with a right axis deviation. You can make out here that lead 1, the QRS is negative and AVF is positive. This is the ECG of left atrial enlargement, and here you see that there is a clear-cut bifid P wave, and in the lead V1 there is a negative terminal deflection of left atrial enlargement more than 1 millimeter in size. In biatrial abnormality, you will find that there are certain features of both the atrial enlargement, namely you have a V1 very prominent negative deflection and very tall and peak P wave in lead 2. In V5 also, sometimes you can find a positive and a negative, that is a biphasic P wave. Coming to the ventricular hypertrophy, what you see normally is that there is a small R followed by a deep S wave in V1 and a small Q, that is a septal Q known as, and a predominant R in lead V6. In left ventricular hypertrophy, the S wave in V1 becomes quite deep and the R becomes tall. We'll be coming to the criteria of diagnosis of left ventricular hypertrophy by voltage criteria in subsequent slides. Similarly, in right ventricular hypertrophy, what will happen is that the R will become tall in lead V1. It may be RS complex or it may be monophasic R with associated T wave changes. Similarly, in V6, normally what you have, there is no S wave here. However, here there is a persistence of S wave which indicates RV forces in lead V6. Now, this is one of the ECGs suggestive of left ventricular hypertrophy and right ventricular hypertrophy placed simultaneously. See in the left ventricular hypertrophy a deep S wave in V1 and V2 and a tall R wave in V5 and V6. The similar findings reversed in right ventricular hypertrophy, where you have a tall monophagic R in lead V1 with secondary STT changes. Here also you have a secondary ST and T wave changes because of the left ventricular hypertrophy, also known as a LVH with strain. And here also in lead V1, V2, V3 and up to V4, you have a RV forces with strain pattern. So what are the criteria for diagnosing right ventricular hypertrophy? That is RS ratio more than 1 in V1, V2. The QRS complex should be narrow. P pulmonale may be present, and right axis deviation is quite common in this scenario. This is again depicting the same, that the V1, V2 RS ratio of more than 1, R being 9 millimeter and S being 6 millimeter, and QRS is again narrow complex less than 120 milliseconds, depicting RVH. This is the finding where you have in the normal ECG compared to the RVH ECG. V1, V2, V3, hardly any R. Here, a dominant R. Left ventricular hypertrophy has got many criteria, and whichever you are comfortable with, or you can deploy separate criteria as per the requirement. So one simple criteria is look at the S in V1 or V2 and R in V5 or V6. If the sum of these two is more than 35 millimeter, it is suggestive of a left ventricular hypertrophy. The Cornell criteria is that S in V3 and R in AVL more than 28 in men or more than 20 in women indicates left ventricular hypertrophy. However, there are point scoring system also, that is the Romet point scoring system, and Framingham criteria, where you see that R in AVL more than 11 millimeter and R in V4 to V6 more than 25 millimeter will indicate a left ventricular hypertrophy. Similarly, a deep S, that is V1 to V3 more than 25 millimeter isolated, can suggest left ventricular hypertrophy. Similarly, sum of S in V1 or V2 and R in V5 or V6 more than 35 millimeter will indicate a left ventricular hypertrophy. Or also, if you take R in lead 1 and S in lead 3 more than 25 millimeter, again indicative of a left ventricular hypertrophy. So you must familiarize with whatever you are comfortable with, interpret many ECGs, see voltage, also see the build of the person. Sometimes you will find that normal young adults with thin chested wall can have a high voltage in the ECG, but there's no actual left ventricular hypertrophy if you do an echocardiography, and there's no other structural heart disease to qualify or indicate that left ventricular hypertrophy is pathological. So you must be careful and take into consideration those issues as well. Here is a pictorial depiction. You find a deep S wave in V1 and tall R wave in V5 and V6, and the sum of these two is more than 35 millimeter, indicative of LVH. Similarly, this is the ECG indicating a deep S wave and tall R wave in V5, along with strain pattern, that is STT changes in leads containing tall QRS complexes. Biventricular hypertrophy is classically seen in moderate to large VSD in children actually, and this is known as a Katz's-Wastel phenomenon, whereby you have a large biphagic QRS complexes in lead V2 to V5. Sometimes you have a biventricular hypertrophy and you have to find out subtle signs which may indicate, say, presence of LVH in presence of RVH. So what are they? A right axis deviation, a right atrial enlargement, and a deep S in V5, V6 in presence of LVH may indicate an associated RVH. Similarly, what are the additional signs indicative of LVH in presence of RVH? You may have tall R wave and deep S wave in V2 to V5, and QRS amplitude more than 50 millimeter is generally indicative of a biventricular hypertrophy. The other pattern of the ventricular hypertrophy can be diastolic overload, particularly supposing in a severe regurgitant lesions like chronic severe aortic regurgitation, you will have a diastolic overload of the LV. Here what you see is tall R in lateral chest leads V4, V5, and slightly concave upwards ST with a tall and peak T waves. These are indicative of a diastolic overload. Similarly, sometimes diastolic RV overload, you may find a QR complex in V1, which is suggestive of a diastolic overload. Of course, it will require confirmation by further imaging, particularly echocardiography, and clinical examination put together will give you an ultimate diagnosis. Coming to the topic of bundle branch blocks. Now, normal ECG, what does it show you? Normal QRS less than 120 milliseconds in duration, a small R followed by a deep S in V1, and a predominantly small Q and a tall R with concordant T wave changes in the normal ECG in V6. Now, in the right bundle branch block simply means that the right bundle is blocked and the incoming impulse from the AV node and his bundle will pass preferentially over left bundle, excite the left ventricle, and through the myocardium excite the right ventricle. So what will happen? The LV forces or the septal forces initially will cast a small R wave, followed by an S wave, and the secondary excitation of the RV after the LV is excited will cause a R dash. So you will have a RSR pattern or RSR dash pattern, and you may have a different configuration of the QRS morphology, and the QRS duration will be wide, that is more than 120 milliseconds. Similarly, what is happening in LBBB? So here the right bundle is being excited first and left bundle branch is not conducting because of the block, and the LV myocardium is excited through the intramyocardial route after the RV is excited. So the initial LV forces like septal R or septal Q will be missing. So you find there is no septal R or septal Q in lead V6. There will be wide QRS because the transmission is not through the normal conductive system, and it will cast a W-shaped or M-shaped complexes, W in V1 and M-shaped complex in V6, and also in 1 and AVL and other limb leads, right? Okay, so qualifying criteria, wide QRS more than 120 milliseconds. It may vary up to 150, 160 or 180 milliseconds depending on how conduction is slow in the myocardium, and RSR pattern in RBBB, and a notched wide QRS W or M shaped in LBBB. There are common causes of left axis deviation, which we had discussed in the first tutorial, that is the axis between -30 to -90 degrees. It can be normal in elderly and very obese patients. Sometimes due to high diaphragm during pregnancy, ascites or abdominal tumors, you may find that left axis deviation is there. Inferior wall MI, left anterior hemiblock, left bundle branch block, WPW syndrome, certain congenital lesions, and RV pacing may cause left axis deviation. Similarly, right axis deviation, meaning thereby the frontal plane QRS axis is between plus 90 and 180. So it can be a normal variant sometimes. In children, you normally have an axis which is towards the right. Then in presence of right ventricular hypertrophy, quite commonly, in anterior MI, right bundle branch block, left posterior hemiblock, left ventricular ectopic rhythms or pacing, and WPW syndrome again can cause a right axis deviation. So what is bifascicular block? You can have a bifascicular block, trifascicular block, or multifascicular block. There are various names given to indicate that more than one conduction limb is affected. That is, supposing in this ECG, what you find is a left anterior hemiblock, that is the axis is minus. You see here in lead positive QRS complex and AVF negative and 2 also predominantly negative, axis somewhere -60 degree, and a right bundle branch block pattern in V1, V2 RSR pattern. So you have a bifascicular block, that is left anterior hemiblock and right bundle branch block. There's a 2:1 block also you can make out here, that alternate P waves are not conducted. One P conducted, then second P not conducted, third P conducted. So there's a 2:1 AV block as well in this ECG. So be careful while diagnosis, you may have multiple findings in one of the ECGs. Now this is the next ECG where you have a bifascicle block of left posterior fascicle and right bundle branch block. See the axis here. So lead 1 is dominantly QRS negative, AVF is positive. So axis is right axis deviation and the RBVB pattern in V1, V2. You can clearly see it. Again, in this also you will find that there is a 2:1 AV block. So be aware when you have conduction blocks, you may have a multiple conduction block. In fact, if you have a bifascicle block and along with the prolonged PR interval, more than 200 milliseconds, sometimes it is called a trifascicle block also. Very high chances of complete heart block and they will generally require a pacemaker. This is multifascicle block. This is a ECG which is very interesting. If you see there is a variable PR interval, you see PR interval here and you should see PR interval here in the same lead V1, V2, and the complex is changing from the right bundle branch block pattern to left bundle branch block pattern. So alternating bundle branch and variable PR interval, multifascicular block, high chances of complete heart block requiring permanent pacemaker therapy. Okay, after considering bundle branch blocks, let us come to cardiomyopathies. There are certain features which are very, very specific for a particular form of cardiomyopathy. I'll tell you 2-3 ECGs which are characteristic of a hypertrophic cardiomyopathy. Now here, oftentimes we find young people, even adolescents and adults or the athletes coming with this kind of picture. In this, what you note is a LVH, left ventricular hypertrophy. In fact, the QRS of the other leads is merging into the QRS of the previous lead. And there's no doubt about the voltage part of the LVH. Number 2, you notice T-wave inversion in multiple limb leads and chest leads. T upright in AVR. I told you in my first tutorial of basic ECGs, please always look for a T-wave polarity in AVR. T-wave has got no business to be positive in AVR because all the complexes are negative and hence it's an altered T-wave axis. It's very common in apical hypertrophic cardiomyopathy that you find multiple T-wave inversions in leads, limb and chest leads and T positive in AVR. This is known as an altered T-wave axis and it is discordant in the to the QRS complex. And this is classically found in hypertrophic cardiomyopathy. Sometimes athletes' heart and hypertensive heart disease can mimic these changes. So you should be careful and echo will sort out the final diagnosis. Now dilated cardiomyopathy. Dilated cardiomyopathy, as we know that the LV is dilated and its systolic function, that is the LV ejection fraction, is low. In such cases, generally described findings are Goldberger's tried in dilated cardiomyopathy. Namely, there are low voltage complexes in limb leads which are generally less than 0.8 millivolt in amplitude. There's a poor progression of R. If you see here in V1, V2, V3, R has hardly progressed. Up to V4, actually, there is no transition. So you find that there is a RS ratio in lead 1, in lead V4 is less than 1. You note here, R is less than S, ratio of RS in V4 less than 1. And if you have voltage criteria S in V1 and R in V5, it will be more than 35 millimeter or 3.5 millivolt. Also note some sinus tachycardia, which is common in DCM because of heart failure, low ejection fraction. They may have resting tachycardia and other clinical features as well. Now coming to the coronary artery disease. Coronary artery disease is one of the most common encountered clinical entity in our practice. Be it physician, cardiologist, or even other specialties have to deal with coronary artery disease because this is a killer disease and it can present in various subtle ways. The clinical spectrum of presentation of coronary artery disease can be asymptomatic silent ischemia. Person has got no problem. He comes for something else to the hospital and then we find even some non-specific ECG changes, or we find a silent event which has occurred without the knowledge of the person. Chronic stable angina, that means he comes with some symptoms of effort angina or stable ischemic heart disease. They can come as an unstable angina, that is crescendo angina, or very difficult to relieve pain of angina despite routine measures. Non-ST elevation MI and ST elevation MI are the acute coronary syndromes which requires urgent hospitalization and treatment as per the protocols. They may present with bundle branch blocks or some arrhythmias, and finally they can just die suddenly. Sudden cardiac death is not an uncommon mode of presentation of ischemic heart disease, and we should be careful about this entity. Now let's do some introspection and recall ourselves how many times we have found so many STT changes in the ECGs, right? So what are the STT changes which are indicative of a acute coronary syndrome and not a non-specific STT changes? Generally, as I told you, the ST segment is isoelectric and not very horizontal. Here what you find, it's depressed and horizontal. Here you find it is almost horizontal to downsloping and depressed from the J point. J point is somewhere, if you come here, isoelectric point, compared with the PR segment, you will find that it is depressed, downsloping with T inversion. Similarly, sometimes you will find that the QRS is slurred, the ST is depressed, but T is upright. This is a downsloping ST along with T inversion, and this is a subtle ST depression and biphasic T, which all may account for a non-ST elevation MI on ECG, provided that the patient has come with a clinical scenario suggestive of acute coronary syndrome, right? So you must be able to differentiate between subtle changes of NST-MI in a clinical scenario and a routine ECG in a asymptomatic patient which shows some ST flattening, minimal ST depression less than 0.1 millivolt, not associated with T wave changes or non-specific T wave changes, which do not qualify it for a NST-MI. And of course, once you do cardiac enzymes, you will find that troponin particularly is positive, which will confirm the diagnosis of NST-MI and lead you to a particular protocol of the management strategy. ST elevation MI. Now, ST elevation MI can be present as more than 1 millimeter ST elevation in 2 consecutive anatomically related leads. This should be very clear that if you are seeing only one lead which has got a ST elevation and not associated with ST elevation in the contiguous leads, such as V1, V2, or V1 to V4, or 1 AVL, V5, V6, or inferior leads, 2, 3 AVF, any combination, then you will say, okay, this is the acute ST elevation MI ECG. In hyperacute phase, this is the normal ECG. You find PQRS and ST is isoelectric, followed by a well-rounded asymmetrical T wave. However, here if you see, suddenly the ST is elevated and coving upwards. In hyperacute phase, you may have a very tall T and subtle ST elevation or a flag sign. As the MI evolves, what happens in the serial ECGs when you do? Q wave develops, the R wave becomes less and less. Finally, there's actually loss of R and only QS complex may be there. And ST elevation comes down serially and T wave inverts. The remote changes of a MI, if you do a ECG say after 1 year of MI or 2 years of MI, there may be very subtle presence of a Q wave or a decapitated R wave, or you can have a minimal T inversion. ST generally comes to the isoelectric point. So all these evolutionary changes, at what phase of disease you are seeing this patient and doing a ECG will be different as per the time phase of the MI and its evolution. One clinical entity I would like to be aware of is Whelan syndrome. Now, Whelan syndrome is nothing but a deeply inverted T waves or biphasic T waves in V2 and V3. You see here, there's already some suggestion of a miniature R or a QS complex and deep inverted T waves in the V3 up to V4, V5 actually. So Whelan syndrome generally indicates if the patient is presenting with chest pain and these ECG findings that he is likely to have a proximal left anterdescending artery block. This is also known as an orphan's artery because it may result in sudden cardiac death and very high incidence of complications, right? So you should be careful. Such ECG should be immediately evaluated by early angiography and proper treatment. Okay, after the coronary artery disease, let us see acute pulmonary embolism. This is again a very common condition in the clinical practice. In acute pulmonary thromboembolism, other than the signs of, say, deep vein thrombosis or some risk factors in a patient, prolonged immobilization, hypercoagulable state, or any other such things, underlying malignancy. So you must suspect acute PE based on some criteria. Generally, in acute pulmonary thromboembolism, the consistent finding is just a sinus tachycardia. However, the classical pattern, what we find is a S1 Q3 T3 pattern. That is S wave in lead 1, S1, Q and T inversion in 3, S1 Q3 T3 pattern. Also, you will have some suggestion of an acute RV strain if it is a massive pulmonary embolism, because the RV is strained because of the pulmonary circulation getting shut because of the massive pulmonary embolism. And here you will find that you may have a tall R wave in V1, V2 and a ST depression in and T wave inversion in the right-sided leads. Okay. So after these clinical entities, let us come to arrhythmias. Arrhythmias, actually, people are frightened to interpret arrhythmias, but this is the disease where if you go systematically and arithmetically, you will be able to detect a particular arrhythmia, although at times you may find it difficulty and you may have to consult others. You may have to repeat a ECG at a faster speed of 50 millimeter per second speed, or you have to consult your seniors, but definitely it's a very, very exciting field of ECG diagnosis. Arrhythmias broadly will have bradyarrhythmias or tachyarrhythmias. In brady, you have sinus node dysfunction, which can manifest as inappropriate sinus bradycardia, sinoatrial block, sinus pauses, sinus arrest, atrioventricular blocks, which high grade second degree and CHB will cause a bradycardia. However, if it is just a first degree AV block, it may not result in a bradycardia, clinical bradycardia to say so. And of course, asystole, where there will be cessation of the electrical activity of the heart. In tachyarrhythmias, generally two things what we look as whether it is a narrow QRS tachycardia or a wide QRS tachycardia, because both have got a different connotation in management protocols acutely, and whether it is regular or irregular tachycardia. So you can have a regular narrow QRS tachycardia, irregular narrow QRS tachycardia, and similarly regular QRS tachycardia, wide QRS tachycardia, or a irregular wide QRS tachycardia. The other entities which you may find is, one is of course sinus tachycardia, where the rhythm is sinus and the heart rate is more than 100 beats per minute. In atrial, you can have premature atrial contractions, not really qualifying as a tachycardia of significance, I would say, but atrial tachycardia or ectopic atrial tachycardia, multiform atrial tachycardia, generally common in COPD and respiratory diseases, atrial flutter and atrial fibrillation are the common arrhythmias. Junctional tachycardias can be there, just plain junctional tachycardia, or because of the dual physiology of the AV node, or because of the presence of pathway, you can have a atrioventricular reentrant tachycardia or a reciprocating tachycardia in presence of a AV bypass tract, as in a WPW syndrome. In the ventricular tachycardias, what you have is VPCs, which may be multiform, suggesting a sinister outcomes. You have ventricular tachycardia and ventricular fibrillation. Let us go one by one with examples. Now, what are the pacemakers of the heart? SA node generally fires at 60 to 100 beats per minute. It is the dominant pacemaker. The AV node, it's a backup pacemaker. Supposing sinus node is not firing or firing very slow, then the AV node may take up, that is in the junctional rhythm, which will be around 40 to 60, and a narrow QRS complex because it is rising in the node and conducted through the His bundle and bundle branches. The third level will be, if the AV node is also not firing, ventricular cells, which will be at a rate of 20 to 45, and it will be a wide QRS because it is arising from the focus in the myocardium and not transmitted through the normal conducting system, right? Okay, so let us see sinus node dysfunction. Sinus node dysfunction can present in many ways, as I told you. Sinus bradycardia, profound sinus bradycardia, sinus P wave followed by a QRS complex, but the rate is almost about 38 or less than that. As a exit block in which what you will find is, see the P waves. Here, the second P wave is conducted, and suddenly here you find that there is the PP interval is here, and here one P wave is missing with no QRS complex. So that is a SA exit block 2:1. Sometimes you can have long sinus pauses. That is, you see here the already heart rate is very low, but there is a long sinus pause, no activity, followed by another sinus beat, interspersed by almost more than 3 seconds gap. More than 3 second sinus pause is a significant sinus pause, generally resulting in syncopal or pre-syncopal episodes. Patient will come with symptoms and generally will need a pacemaker implantation. Now here, this is also known as silent atrium. Why silent atrium? Because there is no activity from the SA node or from the atrial myocardium. You find the irregular junctional rhythm. You see here, it's a narrow QRS, so it has to be junctional rhythm, not preceded by any sinus P or atrial P. So, and there's a long pauses in between. This again qualifies that the sinus node dysfunction is there. Patient may be symptomatic and may again need a pacemaker therapy. Another form of presentation of sick sinus syndrome or sinus node dysfunction, as we call it, is tachybrady syndrome. This is actually a recording of Holter, and here what you find is a junctional beat followed by a long pause, again a junctional beat, irregular, again a pause and a junctional beat, and in between it the rate accelerates, and this is again not preceded by any P or irregularity, suggesting that it is a fibrillation, but it's generally, if it is regular, it's a junctional rhythm which is almost more than 100, and again it is followed by a bradycardia preceded by sinus P wave. So you must be very careful while analyzing long lead 2s or Holter recording. If you have a long strip recordings, that what are the abnormalities suggesting sinus node dysfunction. AV nodal blocks. We all know first degree AV block, mainly a prolonged PR, second degree type 1, that is Wenckebach phenomenon, and second degree type 2, that is significant 2:1, 3:1 or 4:1 higher grade of heart blocks, and third degree AV block, that is complete AV dissociation or complete heart block. Let's go one by one with examples. Okay, so here I have put all the strips of various degrees of heart blocks one above the other for easy identification. Okay, so prolonged PR, first degree heart block, you see here the PR interval is almost more than 7-8 small squares, thereby it is almost 300 milliseconds. This qualifies for first degree AV block. This can be just an indication of an AV nodal disease, or it could be just drug induced AV nodal block such as beta blockers, digitalis, or diltiazem group of calcium channel blockers. So you must be careful in asking the history of any drug intake which may cause a reversible first degree AV block. Once you stop the offending drug, the rhythm and the PR interval may become normalized. Second degree type 1 or Wenckebach phenomenon, you have progressive PR prolongation. So if you go from here, this is more or less PR normal. Here the PR is little prolonged, again prolonged, followed by a P which is not conducted. There's no QRS here. So this is a Wenckebach phenomenon where there is a progressive prolongation of the PR interval followed by a non-conducted P wave. It may not require any treatment per se. It is common in young people who are athletes, marathon runners, hypervagotonic people. It may go away. It may occur in sleep actually. Normally physiologically it may occur in sleep as well and not qualifying for a definitive therapy. But you must be careful if it is indicating a structural heart disease. Second degree type 2 block, as I mentioned, it is a fixed block where every second, third or fourth P is conducted. Like here, one P followed by QRS, the second is not conducted, the third is not conducted, and the fourth is conducted. Similarly here, the next P is not conducted, and then it is conducted. So it's a AV block, second degree high grade. This is definitely indicative that the patient might develop complete heart block and require a definitive therapy. Sometimes these kind of blocks may be intermittent. One ECG may show PR prolongation or a Wenckebach or a AV block and not show anything on the other recordings. So you must be very careful. Patients may have an intermittent AV blocks despite having a structural AV nodal disease. Complete AV dissociation, of course, has got no relation between the PQRS, and the QRS originates either supraescision when it will be narrow or infraescision when it will be wide, arising in the ventricular myocardium. So here you see P, constant PP interval, and QRS wide, bizarre, arising somewhere in the ventricular myocardium, and constant RR interval, but no relation between P and QRS. So complete AV dissociation or complete heart block, indication for a permanent pacemaker. Now let us come to the atrial tachycardias. Multifocal atrial tachycardia. This ECG I have put only to show that multifocal atrial tachycardias can be very fast as well. Generally they are in the range of 120, 103. Heart rate is somewhere between 100 to 180. In this ECG it's about 162 calculated by the long lead 2 and multiplied by 6. There are at least 3 different P wave morphology. Now you go to the lead which shows the P's prominently, and here either lead 2 or 3. You see the P here, CP here, and CP here. They're all different wave morphologies. So 3 or more different P wave morphologies and a heart rate which is more than 100 with probably variable RR interval qualifies for a multifocal atrial tachycardia. Very common with patients with pulmonary disease, COPD, cor pulmonale, pulmonary arterial hypertension. Sometimes it is confused with atrial fibrillation, which is again a common arrhythmia in clinical setting. And there you must look that there are no P waves, there are actually fibrillatory waves. So a careful examination of the ECG is required. What is a wandering atrial pacemaker? Wandering atrial pacemaker or a multifocal atrial rhythm is nothing but when the heart rate is less than 100 and you have different P wave morphology arising either in the sinus or in the low atrium or in the left atrium, then you say it is a wandering atrial pacemaker. Coming to the ectopic atrial tachycardia. Now, ectopic atrial tachycardia is when you have a focus, automatic firing focus in the atrium myocardium, then you say ectopic atrial tachycardia. It can be anywhere in the right atrium, any of the structures of the right atrium. It can be in the left atrium also. So the P wave morphology will be different as per the focus of the origin of the atrial tachycardia. So here what you find, heart rate is about 120 per minute. Note negative P waves in lead 2, 3 AVF, okay, and positive in V1. So this is arising from somewhere causing a negative P waves in 3, that is the left and posterior side of the LA or coronary sinus. It can be fast and insistent, causing LV dysfunction. So if it is persistent or incessant and causes a tachycardiomyopathy, right? So you must be careful while evaluating atrial tachycardia. They generally require EP study, that is electrophysiological study, followed by RF ablation. Atrial flutter, these are very common arrhythmias actually. If you know that they have flutter waves, which is in the form of sawtooth waves, you very clearly delineated here, and they have a variable conduction. So flutter rate, atrial rate is about 250 to 350, and the ventricular rate will be determined by the AV conduction. So you may have a 2:1 conduction. In fact, if you see regular narrow QRS tachycardia at a rate of 150, it is atrial flutter, and atrial flutter unless proved otherwise, right? So in this case, if you see very rock steady heart rate, and generally it is showing a 3:1 conduction, okay? Now atrial fibrillation. Atrial fibrillation, the qualifying criteria on ECG, it's a very common arrhythmia. All of you have seen the ECGs of atrial fibrillation in your MBBS days and clinical setting. There's absent P waves, no P waves. There's a presence of fibrillatory waves. As you see, these are coarse fibrillatory waves, of course, but undulating baseline indicating a fibrillatory waves. Irregular RR interval. You say no two RR are of same duration. So irregular RR interval and atrial rate of about 400 to 600. Ventricular rate again depends on the AV conduction permitting the heart rate. They will require rate control or rhythm control measures depending on the clinical setting and how the arrhythmia is arising and what is the underlying structural heart disease. Okay, let us come to another narrow QRS regular tachycardias, that is AVNRT, AV nodal reentrant tachycardia, also commonly known as the PSVT. Both AVRT, that is orthodromic AVRT, and AVNRT are called as PSVT because on a surface ECG, you might not be able to differentiate between these two entities unless you do EP study and find that there's a pathway, then it is a AVRT. And if it is just a dual physiology of the AV node, it is a AV nodal reentrant tachycardia. Subtle differences may be there on the ECG. See here, regular narrow QRS tachycardia at the rate of 140 to 280 beats per minute. The P waves are generally not seen because they are buried within the QRS. Sometimes they may be retrograde, causing a pseudo R in V1, V2 or pseudo S in inferior leads. They are generally triggered by a PAC and structurally the heart is normal. So you see regular narrow QRS tachycardia almost at the rate of about 160 beats per minute, and EP study did reveal that it is a AVNRT and successful slow pathway ablation was done. The other form of PSVT, as I was telling you, is in the presence of axillary pathway, that is orthodromic AVRT, where the antegrade conduction is through the AV node and the retrograde is through the pathway. That is why the QRS complex remains narrow. If it is an antidromic tachycardia, meaning thereby that the antegrade conduction is over the pathway, then it will be a wide complex tachycardia. So it is again a regular narrow QRS, rate may be 200 to 300 beats per minute. The P waves again are buried within the QRS or they may be retrograde. ST depression and T wave inversion may be present in these tachycardias, not like AVNRT. And again, the heart is structurally normal and they require again an EP study and RF ablation. Antidromic AVRT, of course, as I said, will be a wide QRS tachycardia because of the antegrade conduction over the pathway. Coming to the ventricular arrhythmias, now PVCs, we all know these are wide, bizarre QRS complex and they have a long compensatory pause after the PVC. They can be unifocal, that is, when they are rising from same focus and pausing same morphology in the ECG. However, multifocal PVCs, here if you see, this morphology is different and this morphology is different. So they are arising basically from a different foci in the ventricle and they are actually more sinister, I would say. Coming to the ventricular tachycardias, ventricular tachycardia is an emergency. You can say so because the moment you find a wide QRS tachycardia, you yourself think, is the patient going into VF, pulseless electrical activity, or will require some emergent shock, ICU admission, and some other measures? So you have to be very, very proactive in evaluating and diagnosing VT vis-a-vis SVT with aberrancy, which can also cause a regular wide complex tachycardia. I am not going into the details of how to differentiate between a VT and SVT with aberrancy, but there are laid down criteria which you must have handy when you are faced with such situation and evaluate immediately to focus on the appropriate management. So as VT suggests, it's a wide QRS arising in the ventricles, rate 150, 180, very fast, 240. You can have fast tachycardias or slow ventricular tachycardias. There are no P waves visible in this ECG, of course, but AV dissociation, if you can make out a P wave with AV dissociation, it's one of the features of VT. Also look for capture beats or fusion beats and Brugada and Joseph sign which may corroborate that it is a VT. I'll just come to these in next 2-3 slides. So what are the signs suggestive of VT? One is, if you see here, there's a P wave present here. There's a P wave deforming the QRS here. There's again a P wave at the terminal aspect of the. So when you have AV dissociation, when you have a capture beat, that is fortuitously one capture beat or a sinus beat has come in between the two ventricular origin beats. Then, and a fusion beat is nothing but a fortuitously timed sinus beat merging with the ventricular tachycardia beat. This is fusion beat, also known as a Dressler's beat. And these are the signs, that is AV dissociation, capture beat and fusion beat, which favors the diagnosis of ventricular tachycardia. Now, what are other signs? As I told you, Brugada sign. Brugada sign is nothing but, if you see here, measure the distance between QRS complex to the nadir of the S wave, more than 100 millisecond will qualify for a diagnostic criteria for VT. Similarly, the Josephson sign is a notch at the downslope of the S wave or at the nadir of the S wave. This is Josephson sign, and it's quite specific and sensitive sign for VT. Polymorphic VT generally occurs in a long QT, which is either congenital or acquired. There is a twisting of the beats around an axis, and that is why twisting of points or torsade, this is known as in setting of long QT. Otherwise, polymorphic VT can occur in ischemic VTs also. And here, generally a trigger is a short cycle. If you see here, short and a long cycle will precipitate a polymorphic VT. This is dangerous, will require immediate cardioversion followed by AICD if indicated. VF, nothing to be spoken about. You all know this is the terminal rhythm. Many times on the monitor you see that patient has got no pulse, he is arrested, he is collapsed, and the monitor is showing just a chaotic rhythm, suggestive of ventricular fibrillation and will require immediate measures, right? Just a word about the paced rhythms. Now, paced rhythms, you will find in your OPD setting that patient is already been implanted a pacemaker, whether a single chamber or dual chamber pacemaker. I'll not go into the details because they require a very, very careful analysis. But what I want to highlight on a paced ECG is that you will find a pacing spike. Of course, these are very, very large spikes which you will not find in the routine ECGs. These are unipolar pacing spikes, and the other today's pacemakers, they have very minimal spikes. So preceding a wave and preceding a QRS complex. So if you find two spikes followed by the atrial oblique ventricular depolarization, they are in the dual chamber pacemaker, that is A pace and V pace. There are many rhythms which can occur in a pacemaker situation like ASVS. ASVS is nothing but A sense and V sense. That means the pacemaker is just sensing, not firing, because patient is maintaining his own rhythm at a regular rate as programmed by the pacemaker. ASVP is nothing but it is sensing the atrium, that is not pacing the atrium, but pacing the ventricle because it is not resulting in the ventricular capture. APVP, pacing the atrium, pacing the ventricle, atrial pacing and ventricle pacing. So any of the abnormalities can be found on the surface ECG, and you have to analyze that. I finish with the arrhythmias now, and thank you for your kind attention. I hope this tutorial was useful to you.